Okay, today talking about update on destruction osteogenesis. This is the basis of gradual deformity correction and lengthening. So last year, we celebrated 100 years anniversary of Professor Ilizarov, and he's the one who postulated all the principles and defined the destruction osteogenesis as a biological process of new bone formation between the surfaces of two segments that are separated by incremental traction. Now, destruction osteogenesis can work as fascial destruction, there is technique of destruction epiphysiolysis, chondrodiastasis, or as calotasis. The calotasis, this is mostly used technique. It's a gradual stretching after the osteotomy. And this is majority of techniques. But there's also destruction epiphysiolysis. It's not that popular because it's not quite predictable. Here you gradually stretching through the growth plate, but it produces fracture through growth plate initially, and then you continue lengthening. We actually done some experimental techniques of epiphysiolysis in the spine on the animals, and you can produce nice regenerate here. We done few of those, but in majority of cases, there was actually accidental technique of destruction epiphysiolysis. This is example of the patient with radial club hand. This is X-rays of the deformity, quite a severe deformity, very shortened radius. We done the osteotomy, apply the hexapod fixator, have to fix the wrist too, and do the destruction. And you can probably notice here that there is some difference. There is two levels of the destruction. You see the level where we previously done the osteotomy, and then there is callus formation, which is accidentally happened in our case when premature consolidation appeared at the level of the osteotomy, and majority of the destruction was done through the calotasis. So it happens. It can help in some cases, especially with very short fragments. Unfortunately, it's less predictable. So majority of the lengthening and deformity correction technique are done through calotasis. And this technique is based on the evolutionarily developed mechanism of fracture healing. When we break out the bone, we have inflammatory phase, reparative phase, and remodeling phase. Now, we can actually take reparative phase and divide it in two smaller stages. Stage of the soft callus. This is where the connective tissue forms between the two fragments, and then they remodel into the hard callus. So the idea of destruction osteogenesis, if you take the soft callus and start gradually stretching it, so applying tension at the biologically developed process of the fracture healing creates destruction osteogenesis. So key point here is a tension stress. This is the idea, and this term was introduced by Ilizarov. This is gradual traction of legal tissues, creates stress that stimulates and maintains regeneration and active growth of those tissues. It's actually not necessarily true only to the bone. He demonstrated it can happen to some other tissues. But we'll talk about destruction osteogenesis for degenerating the bone. So this tension stress has growth stimulating effect and shape forming effect. So growth stimulating effect starts with increased proliferation of the fibroblast. This is the first tissue which coming into the fracture gap or osteotomy gap when you start separating them. And there's also prolongation of osteogenesis. So what's happened with tissues, the connective tissues, as you continue to stretch it, the fibroblasts in the gap, they reorient along the axis of destruction. And you can see this on the experimental slices of the destruction regenerative. You can see that all the connective tissue lined up in the vector of destruction. And then what happened after that, along those fibroblasts, the osteoblasts start forming, and they lie the osteoid and form the bone. So when you continue the destruction osteogenesis in the regenerative, you actually can see the three distinct areas. This is your fibrous interzone, this is your longitudinally oriented connective tissue, and two zones of There is a few different ways the bone gets formed there. One of them, and this is what Ilizarov called preferred way of forming the bone, so-called intramembranous ossification, when those fibroblasts, and majority of them actually end up being the polypotential cells, they start converting into osteoblast and form the bone directly. But when you look in the portions of the regenerate, you can see in some portions the chondroid tissues are forming. And you can see the chondroblasts there that believed to be there as a result of less vascularization, less oxygenation of the tissues, so it goes through the cartilaginous stage and then it forms into the bone. There's also transchondroid, interesting ossification, where actually chondrocyte chondroblast turns into the osteoblast and form the bone. Again, we're not entirely sure about all the genetics going in this stage, but this is three phenomena when you can see here. As for us, for clinicians, what's interesting, during the destruction and regenerate, you can see all three stages there. Two parts of reparative stage, soft and hard callus, and remodeling. So you can see five different zones of regenerate. In the middle, this fibrous entry zone, then it mineralizes into the bone, and then it remodels into the tubular bone or whatever bone you're actually trying to form. So in the fibrous entry zone, finally the bone trabecular start merging, which you can see here, and form continuous bony regenerate. Again, initially it's a woven bone, and then it remodels into the initial bone. In the majority of cases, when we're doing the long bones, it remodels into the tubular bone, what we use for the bone loading. What's interesting thing, and that was one of further Ilizarov discoveries, that bone forms in the vector of destruction. So you can do lengthening, or you can do transverse destruction. And his experiments, this is the experiments on the dock, you can see when you cut off fragment of the bone and you can pull the bone transversely, the regenerate follows and it forms the bone. Ilizarov actually used it to manipulate the shape of the bone. So in majority of cases when you do a lot of lengthening of congenital deformities, you still can restore the length, but the shape of the bone, the muscle mass will never restore again. This bone is designed to be different. This leg is designed to be different. The shape is different. So you can apply traction to form the bone. It's not nice and soft, tissue muscular bone, but it can serve its cosmetic purposes. You can actually do it through different tissues. This is one of the examples of a sacral for the patient. That was our idea on the video, how we can actually do the osteotomy and gradually separate two parts of the pelvis to form the bone, to widen the space of the pelvis, in particular, this patient, just to make your life easier. And this is what happened. You can see the very nicely transformed bone. There is no sacrum there, but two iliac wings are connected with newly formed regenerate. But what's more interesting, what Ilizarov noticed, when you do the lengthening, when you do any time of destruction or osteogenesis, there's increased blood supply to the extremity. And first notice, and actually you can see on your patients, the leg, usually one of the legs where you do the lengthening, become much, much more hairy. There is more hair growth. It's one of the examples of increased blood supply. And Ilizarov actually developed the technique of transverse destruction to increase in blood supply. And there was an entire department there dealing with arterial problems for diabetic patients or any other results, any other conditions which result in a decreased blood supply. It became actually a very interesting topic, which you're going to hear today, unfortunately in a recorded presentation, about using the transverse destruction to increase blood supply. So overall, destruction osteogenesis is a unique biological process of new bone formation under influence of tension stress. And until it's interrupted by traction forces, it's the same biological process of fracture healing, and incremental force makes a soft callus continue growing and producing destruction regenerate. There are some conditions which need to be met to allow this process to go. First of all, you have to be very careful and preserve osteogenic tissues. So not to skeletonize the bone too much, not to pull the periosteum out. You need to have so stable, but this is important, not rigid fragment fixation. So biomechanics is important. And you need dynamic loading or dynamization. And that will be my next part to share you what's new development here. If you look at the original Ilizarov frame, there was no half pins. There are a few reasons of it. There was no good metal in there, and Ilizarov didn't believe in very rigid fixation. He loved the wires, thin tension wires. And these tension wires, they don't produce cantilever bending, they arch bending, which is dynamic loading there. If you look at contemporary frames, and this is actually our frames, which we love wires. I'm from Ilizarov school. I have to have at least one wire in the frame, otherwise I'm not happy. But in those frames, you don't see no wires. So there is no much of dynamization as the elastic fixation. So what we have to do now, we need to do something to dynamize this frame. And this is why, the buzzword now, the axial dynamization is going around the world of external fixation. It's a not new idea. Actually, the first dynamized external fixation frame was done by Di Bastiani. He used special elastic ring, which he would put on the bar to optimize the healing, because he discovered that pins are too rigid. And when the frame is too rigid, there is no need for bone to form because it's stable. So there is different dynamization technique actually were developed. You can do partial frame removal of pins and wires. Yeah, it's dynamizing the frame, but it requires either trip to R or some unpleasant procedures of the patient. You can partially remove our connecting rods, or you can untighten the nuts. You can do some different over-lengthening technique when you lengthen a little bit low and then you compress back, or do the accordion maneuvers going back and forth. They're all one way or another producing better regenerates, and you can see the publication there. But we love to use special devices, and there is a couple of new dynamization devices. This is one. This is a demonstration on the specimen in the cadaver lab, how the dynamization works. So this device, this is spring-loaded dynamizer. It's available commercially. So you can put it in between straight rods to dynamize the frame. So when patients walk, they produce that little dampening effect and do axial dynamization. This is one of the examples of our patient. This is adolescent Blount's patient. I will not go on the technique, very typical technique. Majority of you done those Bones workshop. So we done the osteotomy, applied hexapod fixator, done the correction, and then you can see the regenerator is not forming normally. So what we did, we switched from 6 rods to 4 rods with dynamizers. And this is patient in this frame with 4 rods with dynamization. Very important, patient has to walk. If there is no loading, there is no dynamization. We're actually working on some new interesting ideas how you can dynamize not walking patient, but it's not topic for today, and we're not ready to present you with technique yet. But it's very important when patient walk, and when you walk, you can see very good improvement on the healing. And this is, again, the restoration of the patient's alignment, like you can see now, that both straight legs. You can do it on any external fixation frame. This is actually the hip fusion, and this is one of our ladies, and unfortunately we have to go to the hip fusion. That's not a nice procedure, but in some situations there is no solution, and you can see you can use dynamization there. Unfortunately, that spring-loaded dynamizers, they're a little bit too hard. They require quite a bit of loading. No, our typical Texas-sized patients, they're okay. They produce enough load, but the smaller, children, they require something less rigid. And this is why we developed, this is still experimental. Those flex disc dynamization models, they should be available soon, but we just print them on the 3D printer. It should be available, commercially available sometime this year. And this is what we've done on this girl with rickets. And you can see bilateral deformities. We do one leg at a time, so we finish the correction with hexapod frame, and then we switch to dynamizers, and you can see the 2 levels of deformity correction. Obviously, it's multi-apical again deformity, and we switch here to dynamizers. You can see they're actually radiolucent dynamizers, and this is here regeneration. was produced very, very fast and nice. This increases the bone production tremendously. And this is her actually on the second leg. You see the first one is already corrected, and she's comfortable because we were a little bit kind of worried. So you dynamizing the frame means you destabilizing the frame action. All of those dynamizers and the idea of dynamization, you not allow any rotational or flexion deformity. It should be only axial loading. This is how the thin wire is working. So that was the idea. So, and we were kind of worried the patient will not be really willing to put the weight when you decrease some stability in the frame. But we were surprised. They actually love it. So now axial dynamization, it's our method of choice for all patients. We used to wait until we see something bad and then, oh, let's dynamize it. No. After we finish the correction, finish the destruction, we have the straight leg for all of our patients. 3, 4, 5 weeks after that, we put dynamizers there. It's become default method. We have much shorter rehabilitation times right now. This is another example. This was the fibular transport into the a huge defect on the tibia. Unfortunately, it was premature loading and transported fibula broke. It's actually about 50% of complication rate of broken fibula when you transport it here. So we put the patient back in frame, done the flexible rod along this long fibula. But we immediately, actually, in this case, immediately put the dynamizers, and you can see the frame with dynamizers right there. So the dynamization device connected with struts, rapid adjust struts, they allow to connect maybe not entirely non-parallel rings. And this is the patient with full weight bearing. Again, we were surprised, but patients feel more comfortable actually well when you put the dynamizers. And here's a little example of what's going. Can you imagine if you just put 2 pins, not using the wires, and load the frame, load the bone? So what's going to happen? The fragment's not going to go vertically. It's actually start bending, right? This is what you're going to do. You're going to have bending, but when bending occurs, because there is 2 pins, there's some effect on trying the fragment slide on the pin. And this is what causes troubles for the patient. This is not nice. This is definitely not the desired technique. So when you put dynamizer, again, it doesn't happen exactly as I'm showing you here. It's just little animation. But dynamization dampers the frame. And now when you load it, it actually avoids some or most of the pin bending. And if you look at now typical fixation, let's say for the proximal tibia with 2 half pins and maybe 1 wire, or only pins, what happens? That's exactly what happens. And this deformity of the half pins, it leads to deformity or deforming forms, such as on the fragment. We actually done some testing. We put this out, typical configuration, 2 half pins in the wire in the MTS machine, and we load the frame. And this is what happened. When we put 50 kilogram of the load, it's about weight on our average, not typical exercise patient, but average pediatric patient. You see, at the end of fragment, we have 5 millimeters of anterior bending. That's a bit disturbing. When we replace those rods with dynamizers, we still have this bending, but it reduces to 1.7 millimeters. So it's tremendous decrease. So those dynamizers not only stimulate loading, they actually remove the bending of the pins which you don't like. And we've done some tests with different frames. So this is the graph. On horizontal part, there is a force. So the more kilograms you do, the more displacement it goes. This is when you load in the frame. And then when you're unloading, you can see the curve is a little bit different because this is a sum of remaining deformity in the pins that goes slower. And we've done it on different frames. We actually published these results. You can read it in Journal of Limb Length and Reconstruction. And this is the cycling machine. You can see how the fragment, even with the dynamizers, get a little bit of displacement. And interesting, if you take the all-wire frame, it's a beautiful axial loading. So not only you use the transverse, but you see it's almost, 45 degrees graph, which is more load, more bending. And when you remove the load, it's coming back again. When you take all pinned and wire constructs, when you add pins, your graph is more rigid. It's less displacement with more loading. You see, you don't have that nice of axial loading. when you put the dynamizers, metal dynamizers, look what happened. Initial curve is actually much more vertical, even more vertical than wires. So it means you have more displacement. And then when dynamizers goes out of all of the lengths, this curve becomes parallel to the wire curve. So you continue same dynamization. It's only not dynamization, it's just destabilization of the frame. And of course, the plastic dynamizers do the same. They're much easier to displace initially. So this is our idea. Again, this is the article. So we believe in dynamization. But there's another question right now. When do you want to dynamize? Right now, we dynamize all of our patients in frame. This is the default technique because we believe they actually heal better. But there's also new interesting concept of reverse dynamization. Remember, if we will talk about biological process of fracture healing, initially, there is no surgeons to fix the leg. So when the leg is broken, actually the biology forms the callus. The callus is there to immobilize the fracture sites so the blood vessels can grow and osteoblasts can fix the fracture. So why cannot we try to reproduce the process? So this is called reverse dynamization. We actually done this on the goats. We created the fracture. We put static fixator for 8 weeks. We put dynamic fixator, dynamizers immediately for the 8 weeks. And one of them, 3 weeks, we put actually dynamizers here. And then for 5 weeks, we make a rigid frame. And all animals were working, they're all comfortable. Even with dynamizers, they were using there. So see, our goats were happy there, of course, until we killed them. So at 8 weeks, we euthanize the animals. And this is the static callus. This is what Ilizarov called a very nice and good one. Yeah, it's a good callus, but unfortunately, it's not that big. And we know some of the complications of fractures of regenerate. This is completely dynamic frame, gives you kind of a little bit bigger callus. But this is reverse dynamization. It's not only big, it's much better and faster remodeled. So here you can see amount of the bone forming, and obviously reverse dynamization gives you the biggest callus, but what's most important when you try to break it, so you need more forces for the reverse dynamization pulse. So this is all of updates I have for you. There is much more interesting things coming, and we're still working right now on the idea when and how you can apply reverse dynamization for the destruction regenerate. I want to finish with my favorite words from Ilizarov. A doctor must learn from the nature in order to correct your mistakes. Thank you very much.